Good afternoon, everyone. You just heard sitting is the new smoking. So let's not smoke. Let's stand up for a bit. Let's just all stand up for a bit. And that way, at least I can get your attention on what I will talk about. Okay? So let's stop smoking and let's get going. Okay, please have a seat. Thank you. Okay, so my name is Tarun Jain and I'm a assistant professor at Northern Arizona University. My primary area of interest is biomechanics. And today I'm actually presenting a part of the research that I usually do with chronic ankle instability. And what I've been trying to actually understand is why do people with ankle sprains keep on having repetitive ankle instability? And so I'll be presenting this part of my research. So as we all know that the lateral ligament complex at the ankle joint is consisted of three major ligaments, ATFL, calcaneofibular ligament, and the posterior talofibular ligament. And anterior talofibular ligament is the one that frequently gets injured the most. And the common activity that injures the lateral ankle ligaments is the inversion and the plantar flexion. So again, unfortunately, I don't have any data for India. I have data for US. So approximately 23 to 27,000 ankle sprains occur every day in US, and almost $4 billion are spent on the management of ankle instability. Though majority of the patients recover completely after the initial episode of the injury, there are still 15 to 60% of patients that develop chronic ankle instability. And this is a huge number. There is something that we are lacking, somewhere we are failing. Why are we not able to get these patients back on track? And that's why, we all do treat ankle instability, but again, so many patients keep coming back to us. And people try to do research, they try to identify what are the reasons, and they basically identified probably after your initial ankle sprain, people may get mechanical insufficiency just because now your ligament is not there anymore. So that could be a reason. Or ligament is still there, but then some physiological measures are messed up. For example, like proprioception. Your ligaments have proprioceptors. Those are probably not working. Maybe the balance is an issue with these individuals. So we have a bunch of factors. We think probably strength is an issue with these individuals. So there are a bunch of things. We still don't know what exactly leads to this chronic ankle instability after getting that initial ankle sprain. So how do you diagnose chronic ankle instability? So you have symptoms of recurrent ankle sprains, or patients may say, well, I just walk and somehow feel I don't have any control over the ankle. So, which is called ankle giving way. Lateral ankle pain or swelling, they might report of the weakness around the ankle joint. They have impaired position sense, and obviously they have less balance. They will complain of that during the functional tasks. They can't really perform those activities really well. So, and there are so many studies. We have a bunch of literature. Functional ankle instability was first identified in 1965. Since then, there are a bunch of papers and we still don't know what causes ankle instability. So people have done a bunch of research. These guys, like Conradson et al., they try to look at the ankle laxity. Is that the main factor to get ankle instability? And they found that not all patients have laxity. And then they also found that some people do have laxity. So is laxity one of the major reasons why we get ankle instability? We don't know. Then people try to look at the proprioception in these individuals. And then obviously the theory was once your ligaments are ruptured, probably your proprioceptors are gone. And that's why people have issues with the balance. And then people looked at different studies, and then the ways we measure proprioception, kinesthetic sense or joint position sense, again, there is controversial research. We don't know. Some people found there were proprioception deficits, some people didn't. So we, again, could not apply proprioceptive theory to ankle instability. Then people thought maybe peroneal muscle weakness. After an injury, people have muscle weakness. That's probably the reason why we get ankle instability. But again, as you see in the slides here, there are contrasting research saying Yes, some people have weakness, some people don't have weakness. Again, we can rule out this time. Sensory motor deficits, so somewhere the postural sway get disturbed in these individuals. Some people found it, some people didn't. Again, the theory was maybe our muscles are fine, everything is fine, but when we have to actually produce the response in response to an activity, maybe that's when our muscles are not responding right away. And that's where some of the studies came and they said the long latency, the short and the long latency of these muscles are not fast enough in these individuals, and that might be the reason why people are getting all these ankle instability issues. So the theory was that probably once person get an ankle sprain, they rupture their ligament, it decreases the proprioception input, and then it forces some of the nearby adaptations. It does affect your central nervous system to a certain extent. And then, as a consequence, you start loading the joint a little bit differently, and it does affect how you basically send the motor output to all these different muscles. And then that's what probably leads to the ankle instability. But the big question was, why do people feel ankle giving way? We still don't know. People have repetitive ankle sprains, but what's giving way? So how do you explain this? And the giving way is explained by the way we define it is the regular occurrence of uncontrolled and unpredictable episodes of excessive inversion of the rear foot, which do not result in the ankle sprain. People just somehow lose the control as they walk. So, so Dr. Liu is my mentor with whom I basically did a lot of research work. So we tried to look at it and we kind of came up with this new physiological measure, unloading reaction. And that's what we were actually trying to look at. And our theory was probably after an injury, there is inflammation. And what happens with inflammation is it might sensitize some of the nerves. And then in addition, that person has a fear of again re-injuring the joint, and that basically changes the triggering threshold. So for example, like if you basically have an injury, the first thing you're going to do to prevent your ankle sprain is probably take the load on the other side and take the limb off. Maybe in these individuals, they just forgot this strategy. They don't know how to basically unload their joint and protect their ankle. And that's what we were actually trying to study. So what we did was, so this was a previous study that we did. We tried to actually put them in different positions and try to see how their ground reaction forces would have resulted. So we basically measured vertical force variation and the flexion angle variation. So what we did was, we had the force plate on which we calculated the ground reaction forces, and then we had 3D motion analysis, like all the Vicon cameras, 12 camera system. And then we were actually trying to see, along with EMG, what do these people do? Like when they go down, what exactly happens in these individuals? And that's what we found. In healthy individuals, as you can see, we had 4 conditions: neutral, non-painful, neutral painful, supinated non-painful, and supinated painful. As we actually changed their positions, we saw that these people gave us a lot more reaction in these individuals. And then we also looked at ankle instability individuals, and their reaction was way, way higher as compared to healthy individuals. So that definitely gave us an idea that there is something messed up in these individuals. Somewhere that motor output in these individuals is not right. But again, the response that we got in these individuals was not that drastic as we basically see in the real patients. So then the next study was, can we actually duplicate ankle giving way in the lab without actually injuring the patient, without causing any ankle instability? Can we actually drastically produce this response? So we basically developed this trapdoor technique. So basically it's just a trapdoor. We asked patients to stand on it, and as they were standing on it, we basically dropped the trapdoor. And then at around 30 degrees angle, it also sent them the electrical stimulation as to give them the sensation of the pain. So we basically tested both ankles, affected as well as unaffected ankle, at least 3 days apart. We basically determined their pain threshold, and after determining their pain threshold, we basically made them stand on the force platform, tied them up, and basically released the trapdoor without warning. So the idea was, we basically wanted to see as they basically forward testing. Okay, and then we had this patient, and these are, and see the patient. Somehow they don't know how to basically activate the muscles, how to basically support themselves. And that's what probably happens in these individuals. And that is completely different response as compared to healthy individuals. Okay, so in summary, basically we were actually able to duplicate the giving way episode in our lab without actually causing the lateral ankle sprain in these individuals. We thought probably this is because of the hyperreactivity reaction. Somehow, even though it's a peripheral issue, as a physical therapist, we always think ankle sprain, let's treat ankle, no issues. But after a certain extent, maybe it's not that simple anymore. It is basically affecting your central nervous system, your spinal cord reflexes. Somewhere it is getting to a level where it's more chronic. And that hyperreactivity to those normal reactions is what we should probably consider. We all know balance training works. But how does balance training work? Are you really improving the strength? Are you really improving the proprioception? What exactly are physical therapists doing when they give proper balance training exercises in these individuals? And our theory is probably what balance training is doing is kind of suppressing this hyperreactivity reaction. You are basically desensitizing some of that flared up responses in the in the patient, and that's what probably making them easier. Further, with balance training, patients are a little bit more confident. They know how to tackle those unbalanced situations. Okay, in our patient population, only 7 out of 24 basically showed the drastic reaction. And the reason maybe we probably didn't achieve enough ankle stretch for each individual, or we didn't get to achieve that pain threshold with each individual. So hyperreactivity, whatever is happening in these individuals, could be probably coming from the central nervous system or something peripherally that as a physical therapist we should be careful about. If ever you get a patient with lateral ankle sprain, think of it, does the patient has ankle instability, and if they have, what could be leading to it? Is there some benefit to reducing down their hypersensitivity, and that might help with these individuals. Again, this is a preliminary study. We have a bigger study going on right now, and I'm in the process of applying for a big, huge grant if we can actually study it more, look at functional MRI, see if the MRI changes in these individuals and see if there is something that we are actually missing, and we could basically incorporate these findings in our treatment methods so that we can, in the future, decrease the incidence of ankle instability. So, in summary, in one word, if you basically get a patient with ankle sprain or with ankle instability, you should just not think of it as a peripheral issue. There might be an involvement of the central nervous system, and that is something that as a physical therapist we should be all concerned about. Okay, thank you for your attention.
Thank you, Dr. Karan, for trying to stabilize the concepts in ankle instability. Any questions? Let me just get into this little thing, because I'm also working on this ankle sprains, especially the acute ones. So one thing which I would like to put some light is the relative position of the talus to the fibula. So with acute sprains, the central sensitization, the peripheral sensitization will definitely come a little later. But in acute stages, if we re-alter the position of talus relative to the fibula, it gives wonderful results. And the recurrence of such episodes of again and again ankle sprains becomes much less. That's a little thing which I have just worked from my clinical practice.
And that's a good thought process, because again, there is evidence that manual therapy does work in these individuals. But there is also, recently we had a paper about a clinical prediction rule on which patients would basically respond well to your manual therapy. And I always tell individuals, it's good to have all these tools in your armory, but also good to know like which patients are going to respond to your treatment. So yes, manual therapy is a good thing. It's probably one of the things that you could actually use in these patients, but also know that not every patient is going to respond to your manual therapy.
Absolutely.
And that is something, and that's where the evidence comes in. And that's the funny part about the ankle instability, that not every patient is going to have this like talocrural coupling, the issue that you said, like the talar position or the fibular position is basically anteriorly placed or posteriorly placed. Patient presents with so many different criteria, And as a physical therapist, again, we just don't have any one intervention that works in our favor. And that's where your clinical expertise comes into place, where you basically assess the patient, identify what all factors. It's probably there that proprioception will be messed up in these individuals, maybe they have a ligament laxity, and you may have to work on a bunch of factors. Or maybe at times you have a patient, you try to examine the patient and everything seems all right. And that's the beauty of working with humans.
Absolutely.
It's never a straightforward thing.
Absolutely right. Actually, it's a total different execution of things in every different individual because the trauma does not understand any biomechanical principle that can come in any direction. Very rightfully said. Thank you.
Thank you.